Hello, my name is Dr. Shanda Blackmon. Welcome to the Baylor College of Medicine Lung Institute podcast series. We're here to communicate with all of our care providers, our learners, and our community, as well as patients, about how to improve lung health, how to educate you and all of the people around you about ways to prevent lung disease, treat lung disease, and maintain lung health. Hello, my name is Dr. Shanda Blackmon, and I'm the director of the Baylor College of Medicine Lung Institute. Today, for our podcast, On Air, we'll be talking with Dr. Julina Ongkasuwan, who is our head of our division and one of the world's best known people who can reinnervate the vocal cord. So welcome, Julina. Tell us a little bit about you.
Thanks for inviting me. I really appreciate the opportunity to be here. Well, I guess I am a laryngologist, which means that after my otolaryngology training, I did a fellowship in just the larynx. And then actually, I also did a fellowship in pediatric otolaryngology as well. So my practice does actually cover the whole lifespan with a specific focus just on the larynx and specifically vocal fold mobility.
And when you say vocal fold mobility, typically we have two nerves that go to our vocal cords, the recurrent laryngeal nerve on the right and the left. And when those nerves get damaged, whether it's tumor infiltrating into that area or a surgeon cutting those nerves or trauma, any myriad of reasons can cause the vocal cords to not have that nerve innervating it. And when I was at another hospital outside of Houston, I used to ship patients down to you to fix this. You were so well known. So tell me a little bit about who is the best candidate for getting their vocal cords fixed if they've been damaged?
Right. So the first part is that the vocal folds do a ridiculous number of things, right? So they're the gateway to our airway. So the way the vocal folds work, right, you've got your trachea, your windpipe, your vocal folds are on top. When you breathe, they have to open to let air in so you can breathe. And when you talk, they have to close and so that they can vibrate and generate sound. They are also part of swallowing as well. They're not the be-all and end-all to swallow, but they are one of the things that help prevent things from going down the wrong way. So
if they don't come together and you go to swallow, the liquid goes down into your airway and your esophagus because you can't protect yourself from choking.
Yes, it increases the risk of liquids going down the wrong pipe. Now, I want to say that plenty of folks who have vocal fold paralysis are actually able to swallow well because swallowing is incredibly complicated and there are a lot of different muscles that are involved in swallowing. So swallowing is complicated.
Yeah.
But from a voice standpoint, if you can't get your vocal folds together, then the voice will be weak and often breathy, and it's really hard to project. And we find that in the long term, right, that it can be very isolating. There's data on this, right? Folks who can't be heard, they don't want to go out to dinner. They don't want to talk on the phone. They can't get heard in public spaces. It's actually very isolating. And there's a high rates of depression associated with voice disorders, right? We don't think about it, it's just voice, but it's how we communicate and express ourselves.
Yeah, so they're limited to like a whisper. They can talk like this,
right?
And that's about all they can manage.
Right, and it's hard to project. It's hard to get heard over background noise. It's hard to talk on the phone, all of those things that we rely on for socialization, right?
Now, I have some friends that have cervical spine injury, and they actually use a device that enhances the volume of their voice. Now, their vocal cords are working, but they use this device to help them be heard. Right. Do you have a lot of patients that use that?
Yeah, especially teachers. Folks have to work in noisy environments. We have different amplifiers that folks can use. We work really closely with our speech-language pathologists, right? So I always say we're a team. I'm the surgical half. They're the therapy half. So for both voice and swallow, that rehab is done quite a bit by our speech pathology colleagues.
And they're invaluable when you're trying to get people to recover from these complex situations. So they can teach someone where the vocal cords don't come together to swallow in such a way that it protects their airway.
Correct, yes. So all those compensatory strategies and therapeutic strategies for both swallow and voice are done by our speech-language pathology colleagues. So our clinic is all joint. All of our clinic visits are done with a speech pathologist because it's so interdisciplinary.
That makes a lot of sense. So if I'm a patient and I have surgery, and after the surgery, suddenly I'm hoarse, or if I'm a patient and I have a lung cancer and there's a lymph node growing into the nerve and I'm suddenly hoarse, what do you do if I come into your office? What does that look like?
So first, we have to look at the larynx. Unfortunately, we are a specialty of deep, dark holes, so we'll do a scope exam to look at the larynx, either through the mouth or through the nose. Mm-hmm. And we're looking at vocal fold mobility, right? Okay. We're seeing how each vocal fold moves. So the more common situation is a unilateral or one-sided vocal fold weakness. Okay. And that honestly for us is a little bit easier to rehabilitate versus a bilateral. But for a unilateral vocal fold weakness, time course and patient age makes a difference. It does dictate some of our options. Okay. But the mainstay of an early weakness is we will do injection augmentation or medialization of the vocal fold.
So you just move it closer to the middle so the other one can do all the work and this one doesn't have to come to the middle.
Correct.
Okay. And what do you inject?
So we use fillers. There are various different types of fillers.
The same kind of filler that women put in their face?
Exactly. Okay. That's what I tell them, that we're talking about big lips, same stuff.
Only big throat.
Yeah, but we do it in the larynx. And there's a myriad of different materials one can choose from depending on context, like what the patient needs, duration, time frame. And
do you do fillers that dissolve or fillers that stay forever?
So there are no permanent injectables currently on the market. So we all think of injectables as temporary. They last different amounts of time. Again, that's shared decision making as to what the individual needs.
Okay.
And the reason why we do these temporary injections in the beginning is a lot of these vocal fold weakness, movement impairment will get better depending on the nature of the nerve injury. Okay. So nerves are finicky. Like they can stop working because of cancer, they can stop working because of surgery, they can stop working because of trauma. They can also just stop working for no good reason. You wake up with a vocal fold.
Yeah,
paralysis.
I remember we used to have this problem sometimes when we would put an ice slush in the chest. If we were going on heart-lung bypass, the phrenic nerve would suddenly become paralyzed because it got frozen when it was packed in ice. And same with the recurrent laryngeal nerve. Right. And so sometimes an injury like that, all the extracellular matrix, all the parts of the nerve are there. You just need for the nerve to regrow.
Right. So we don't know, unless someone looks me in the eye and says, I cut this nerve, I make the presumption that it can recover. So we go through with the presumption that this nerve can recover, but nerves are slow, and the time frame of recovery is on the order of months, so 6 months to a year.
And a nerve grows really fast, right? I remember when we used to take our board exams, they would always ask us, or our in-service exams, they would say, how fast can a nerve grow? And it was something ridiculous, like a millimeter a day.
Right. So so fast and slow are relative, but the order of recovery is usually on the order of months. So when I try to counsel patients, like this is going to be a year-long process, honestly. So we use these short-term injectables when it's near the time when the voice changed, right? Because we're just playing out the clock. We're trying to see, okay, where are you going to land from a voice standpoint? Okay. So these injectables, we can do them in the office. So I do a lot of them. We numb folks up really well, put a scope through their nose, needle through the neck, and most folks do great. We can also do them under anesthesia if people prefer. Yeah. But these are relatively, they're safe, they're quick, ways to try to augment the voice short term. And we'll do it in post-op patients to help with pulmonary toilet, right? Because the ability to cough, you got to get those vocal folds together in order to generate enough subglottic pressure to get the mucus out. Yeah. So in the immediate post-op patient, we're really thinking about pulmonary toilet. And that's what our data supports, is that it does help with some of the pulmonary complications.
Yeah, and you and your team really help my patients a lot. If there is any problem with the voice or with the recurrent nerve, we'll have you come in early rather than later to help them. So when we're making rounds on the patient, sometimes I'll ask them to cough, and frequently I find immediately after surgery, their cough is fine. And that's because there's a little swelling and it's too early to tell. But 2 or 3 days later, you come by and the patient talks like this. Yep. And they're very breathy when they're talking. That's the best way I can think of to describe it. And then when I ask them to generate a cough, I'll demonstrate and go, and I'll cough, but all they can do is, and there's no like forceful cough.
Right.
And that's how we know the difference, and we start to worry, and we call you guys to come in.
So I always tell folks, in the immediate post-op period when folks are super sick, voice is the secondary outcome. We're really after
Cleaning out
pulmonary
the
toilet,
airway.
right? And trying to keep their lungs able to clear that mucus out. And that's the reason for which we're doing the augmentation.
Yeah. So we can lean in and hear people when they're whispering, but we can't cough for them.
Right.
And they've got to get that junk out of their lungs in order for us to be able to prevent them from getting a pneumonia, essentially.
Right. And our data in the aortic population is that it does help with the pulmonary complications, the lengths of stay. And we found the earlier we did it, the more it seemed
The
to help.
better.
Yeah.
So I have practiced in a couple of different institutions, and I find that in some institutions, the ENT surgeons are very reluctant to do this. And they say, well, we want to see if they're going to recover. We don't really want to do anything. And I'm so glad that your group has done that research to demonstrate that it does help if you do it early on.
Yeah, and it's always going to vary with practice patterns and manpower availability, right? We have an amazing team, and I have partners who chip in if I'm not available. So it takes a team to make these things happen.
A whole force of people, right?
Yeah,
Okay, so what happens if you inject, the voice gets a little bit stronger, the cough is a little bit better, but a year goes by and there's no recovery?
Right. So that's when I talk to them about their permanent medialization options. So this is a little dependent on age. So for our patients who are older, and my definition currently of older is around age 60, nerve reinnervation just doesn't work as well, whether that has to do with neuroplasticity. We don't clearly know, but the data are, and this is actually data out of China where they have the bigger series, that around age 60 is where the voice outcomes just aren't as good with nerve rerouting procedures. So for those that are older than 60, I'll do an implant. It's called a thyroplasty. And so it's a surgery done from the outside. They're actually not asleep completely. Folks are sedated, but they talk to me, and
Is that so that you can talk to them while you're doing it and see?
Yeah, we drill a little hole in the voice box. We take measurements, and I hand carve a little bespoke implant for them based on the voice, and we call it tuning the implant. We listen to the voice. We'll make adjustments to the implant. So it's a day procedure. It's not a huge thing.
That's amazing.
But
So like tuning a piano.
Yeah.
You just change the shape of the implant to give the voice that you want?
Correct. Yeah, it depends. There's different people. There's different spaces. Larynges are different sizes. They need more posterior. Anyway, we can... It's a little bespoke
so it's an
implant.
art.
Yes.
It might be a little bit more of an art than a science at times.
Yeah, so that's what we tell our learners, like learning to do implants. This is definitely the art part of medicine, right?
Wow.
Just hand carving. So that's for our patients who are older than 60, for whom reinnervation I don't think is the best option. We do an implant. And I'll actually do that as early as 6 months if there's absolutely no indication that.
Or if the
like
surgeon
nerve.
said, I cut it out. The tumor was growing into the recurrent nerve. I saw the nerve. I
Right.
cut it in half. There's
Right.
nothing there.
Yeah, if someone tells me I cut the nerve, I'll move to permanent medialization much faster. So I do wait about 6 months for an implant because you have to wait for a little bit of atrophy to occur, or else my implant will be undersized.
Okay.
So you have to wait for natural atrophy to occur.
Right.
But if someone looks me in the eye and says, I cut a nerve, and the patient's under 60, I will go and do a reinnervation right away, because we know the sooner I can get nerves, like new axons in there, the better the voice will be.
So when you say reinnervation, do you mean you take a nerve graft and you put it in interposed where the old nerve was, or do you swing other nerves and bring them in?
So I use the ansa cervicalis, which is a nerve in the lateral neck that innervates our strap muscles.
That's the nerve plexus that we just cut through, blaze through,
yes.
when we're going into the neck
Yes.
and don't pay attention to.
Yes. As
Yeah.
a trainee, we cut the ansa all the time because we think of it as a nerve we don't need.
Right.
And so now my head and neck partners, I'm always like, save the ansa for me, save the ansa for me so I can use it later. So it is a nerve that we think of as that you don't need, right? It's a nerve that's routinely sacrificed during surgery. So I use that nerve, and usually we'll swing it over to reinnervate the larynx. Occasionally we need an interposition graft, but a lot of times we can just get it end-to-end. There's a little bit of a debate I just came back from a national meeting where our neurolaryngology study group was discussing this, because we actually don't have good data versus end-to-end RLN to RLN versus interposition.
Okay.
There are many of us who feel, as opposed to bringing in ANSA, though many of us feel that ANSA just is a stronger reinnervation for medialization.
Well, it's one less anastomosis. It's one less connection that you have to make,
Correct.
and that one's already intact.
Right.
As opposed to pulling in a graft where you've got two things that have to heal.
Yeah, so you have two coaptation sites then. The other thing with the recurrent is an absurdly complicated nerve because it abducts, it opens, it adducts, it closes. It also has sympathetics and parasympathetics. The concern for us is there's more risk for synkinesis where the nerves get crossed if you just bring the RLN to RLN. The thought being the ANSA is a simpler nerve, so that you get more of we're just going for medialization. We're actually not going for movement. We call this a non-selective reinnervation.
Okay.
So to be clear, I call these a medialization procedure. It's just propping the vocal fold over.
Yeah.
Which is in distinction to our selective reinnervation, which is a dynamic procedure trying to restore movement.
Okay.
So they're reinnervations, but they're different types.
That makes sense.
So for true unilateral, which is the most common thing that we encounter, it's a non-selective.
You're just basically trying to bring it towards the center.
Trying to get
And
to
then
the
if you
nerve.
have bilateral vocal cord, some of those patients traditionally from a thoracic surgery standpoint, I had one that I sent to you a long time ago, and he came to me with bilateral vocal cord paralysis. He had a surgery on the right, he had a surgery on the left, and during the combination of the surgeries that were done, by the time he came to me, he didn't have either one of those vocal cords moving. And he did have a pretty high risk of aspiration. He had a hard time managing his secretions at time. And those people, you actually need to reanimate one of them. Maybe medialize one, reanimate the other.
Yeah, so bilateral vocal fold paralysis is a big problem. Like unilateral vocal fold paralysis for us, we've got lots of options. This is our bread and butter, right?
Right.
Bilateral is a much bigger problem, right? So we see it after thyroid surgery, esophageal surgery, anything, because those nerves are running on either side of the TE groove.
Yeah.
So basically any surgeries there put both nerves at risk. And the problem is, depends on where the vocal folds land. Right. If they land immobile but open, then you can breathe, but it's hard to talk. Aspiration is a big risk, and clearing secretions is a big risk. Mm-hmm. That's actually less common, honestly. More commonly, they end up immobile median, in which case they can't breathe, and they're stridulous. And this is a bigger problem. And honestly,
and stridulous means they have stridor.
They have noisy
like
breathing.
Closing,
right?
yeah.
When they go to breathe, the vocal folds are close together. They don't open. And vocal folds are kind of soft and floppy, and they get sucked in, and they can't breathe. Okay. So that's why bilateral vocal fold paralysis is a much bigger problem for us. And in the case that they're paralyzed in the midline position or paramedian and they're having difficulty breathing, usually they require tracheotomy. Because we're not going to do anything destructive to the larynx because most recover, right? Yeah. Like ideally we do nothing and we try to support them through it, but if they really can't breathe, we do a tracheotomy where we place a breathing tube below the larynx to give the vocal folds time to recover.
And do you ever do a nerve stimulator to either one of the recurrent nerves? Does that work?
That's a great question. This was another discussion at the laryngology meeting I was just in.
I wasn't there.
And there was, there's no data for it. So doing e-stim or nerve stimulation, we don't have data for that.
Right.
Another question is whether nimodipine, which is a calcium channel blocker, whether that helps. There's not great data for it. It's used in the facial nerve literature to try to stimulate spontaneous reinnervation.
Right.
The data isn't awesome, but like the downsides of a calcium channel blocker, if their blood pressure can sustain it, is probably pretty minimal. So if the blood pressure can support a calcium channel blocker,
might be risk reward.
Right.
And then I know there's something called the Vivastim that's out there that comes off of the vagal nerve, and sometimes that can be used to stimulate other nerves to recover. Right. Do you ever use that as
We don't have data for it. Yeah. As long as I don't see huge downsides for it, honestly, for non-invasive stim. It's just the same thing with vital stim that they use for swallow. It's a little bit non-specific. I don't think there's big downsides for it, as long as traditional therapy is also used concurrent.
Yeah.
As long as it's not used, as long as you're not neglecting traditional therapy. But you don't have data for it. That's a good question. But most of its time, we had one recently that had a bilateral paralysis, and we just waited. And honestly, in 2 weeks here in the hospital, one side recovered, which was great.
That's great, yeah.
And then we can manage the immobile side as we would traditionally manage it. But so if you have bilateral paralysis that doesn't recover by a year, then we talk about and they're young, they're under 60, and then I can talk to them if they're a candidate for what we call a bilateral selective laryngeal reinnervation.
Okay.
And this is where we are. This is different. This isn't a medialization procedure. This is truly trying to create motion again.
Okay.
So what we do is we take actually an upper rootlet of the phrenic. We dissect out the phrenic nerve, which drives your diaphragm, try to find an upper rootlet of that, and do an interposition graft behind the carotid sheath. We open the back of the larynx and we do a direct implantation into the posterior cricoarytenoid muscle. It's the muscle that drives opening the larynx.
Okay.
That way, when they breathe, the larynx should open.
Okay.
So that's the part to drive breathing. And then in order to drive phonation, talking, we take a little branch off the hypoglossal called the thyrohyoid branch, and we do a little interposition graft from that into the recurrent to drive adduction, so closing with talking. So you're really trying to restore the opening and closing.
That's
motions.
amazing. And how often does that work?
Well, it's hard. This is tough. There are not a lot of patients who actually need this, thank goodness, right?
So it's highly selective. Yeah.
Right. And so I'm part of a little consortium nationwide of people who are doing these procedures, and none of us have huge numbers.
And maybe it's just a handful of people that are even trying to do this, right?
It's a handful. There's about 4 of us in the U.S. that are doing this, 3 of us in the U.S. doing it routinely, and then 2 people in Europe.
Okay.
And so we're collecting our data right now. And the outcomes, it's probably about 50-60% who are really able to get good vocal fold mobility, don't need a trach.
Yeah. And how much of that has to do with that early management? You were telling me you tell your colleagues, don't transect the ANZA, preserve these other nerves.
Right.
Do you think that your success rate really has a lot to do with the way that people are managed early on or even at the time of surgery? Like, do you approach them different? If I have a patient and I know they have a tumor going into the recurrent laryngeal nerve, I've given them neoadjuvant chemoradiation, I know I'm going to have to go in and take out that tumor. Would you tell me to do anything different or just say, go for it, we'll deal with it after?
I don't want to tie anybody's hands. Like, just do what you would do, and then we will manage it on the back end. Though, again, if you know that one nerve is going to be cut during surgery, like, I am happy to come in. Like, if my partners, if they know they're going to sacrifice a recurrent, we usually try to set it up so I can reinnervate them right away, because we know that we can get better voice results if I know they're going to cut the nerve
immediately.
So I'll come in and do it.
All right, well, I'm going to book you next week because I have a lady that has a lung cancer, and she has an AP window lymph node, which means it's in between the aorta and the pulmonary artery. Right. And the lymph node had cancer in it. It was hot on the PET scan, meaning it had a lot of sugar uptake, and it grew into her nerve, and she's hoarse now. And she's gotten treatment. The lymph node has almost completely gone away, but her voice has not come back. And now I have to operate to take the lung cancer out because she's already finished all of her systemic therapy, her IV therapy, and now it's time to do surgery. So maybe getting you involved early on makes a lot of sense.
Yeah. But it's also they have to be young, they have to be the right candidate, all these things. And the other thing with nerve surgery, so injections, implants, these are like the most instant gratification surgery, like no voice, and they have voice when you're done.
Yeah.
Reinnervations are not. This is the thing when I counsel patients, is that you hook the nerves together, but then the nerve,
and then
they have to grow. They have to grow, and we have to sit on our hands and be patient. And it can be 6 months to a year for those nerves to grow in. So that's always, when I'm having these conversations, like shared decision-making, as always, is, do they want something that's going to work right away, or are they willing to wait for their nerve to grow in? And different laryngologists around the country have different opinions on this. I like not having foreign material in the larynx, so no one has to worry about intubation and knocking my implant out down the line. Or I also find that the dynamic control, especially for young people, the ability to yell, the ability to really get the full range of voice is a little bit better with the ANSA.
Yeah.
And our data is not awesome to support that. This is more my clinical experience.
But it's important. I mean, we have to take into consideration all the options and make wise choices. Kids are different than adults.
Right.
People with cancer are different than people who don't have cancer. Traumatic injury is probably managed completely different.
Yeah.
So that's why we have you.
These are long conversations and shared decision making, like where the individual patient is, what their future needs are, what they want.
But this is great. I think the recurrent laryngeal nerve is always quite a mystery for a lot of thoracic surgeons.
Right.
And a lot of times, knowing experts like you helps us to do a better job when we're caring for our patients. I know one of the questions that my residents always ask me is, the course of the recurrent laryngeal nerve. So if we had an image of the recurrent laryngeal nerve, which we'll just pretend like we're putting it up right now, can you just kind of describe to me the pathway of the recurrent laryngeal nerve?
So what I always explain to patients, I was like, it's an absurd nerve. It's a silly way to build people, but that is the way we're built, right? So on the left, it's going to come down in the vagus, in the carotid sheath. It'll go into the chest, and on the left side, it's going to branch off. It's going to wrap around your aorta, and it's going to come up to the neck in the tracheoesophageal groove. That's why every aortic surgery, every esophageal surgery, every thyroid, parathyroid surgery, every ACDF, like this nerve is at risk. On the right side, again, carotid sheath comes down, wraps around the subclavian, and then it comes up again in the TE groove, and it runs a little bit more lateral on the right.
Okay.
Yeah.
And it's when it's wrapping around that subclavian on the right, if we're doing an esophagectomy, we open up that cupola of the lung, the top part of the pleural tent where that esophagus is going, and we're trying to open it up so that we can do our anastomosis.
Right.
And if we're doing a cervical connection, we're trying to open it up so that it passes easily. But we really don't want to skeletonize that subclavian artery on the right, because that's when that nerve gets damaged.
Right.
And then we have to cut the esophagus and the vagus nerve, completely transect the vagus nerve so that when we pull that esophagus up, it doesn't get tented. I think a lot of the injury isn't a direct injury, but it's more stretch and tenting. And then when we're operating on the left side of the neck, when we're exposing the esophagus, sometimes just putting a retractor in and stretching it is all that's needed to injure that nerve. It's not like the surgeon did anything wrong. It's just maybe the person that was helping the surgeon put a retractor in and was really eager to show what they needed to see and pulled really hard and stretched that nerve. Is that right?
Yeah. So I always tell me, nerves are so finicky. You can look at it cross-eyed, and it stops moving. It's so hard for us to predict. We talk about sometimes if you're doing thyroid surgery, you see the nerve and it's like really exposed, and you think, it's going to be all beat up and it's not going to work, and it works fine. Yeah. And sometimes there's no injury to the nerve and it doesn't. We don't really understand why. Like it works or it doesn't work. It's been very humbling. The last 20 years working with this nerve has been very humbling. And nerves are unpredictable, but we do the best we can. But just like when I do tracheal resections, I don't dissect out the nerve. You really try to keep it protected. You don't
really want to see it.
I don't want to see it. I want it protected in its
natural habitat.
Yeah, covered with all its soft tissue friends.
Yeah.
Yeah.
So there are these devices, the NIMS device, or different types of monitoring devices where a special endotracheal tube goes into the airway and it measures the pressure. It senses that pressure and an alarm goes off. So if you stimulate the vagal nerve, because it's connected to the recurrent laryngeal nerve, you put the little stimulator on the vagus and you have not completely transected the nerve. If you get a little signal when you stimulate the vagus, it goes down, loops back up, and then you hear that beep beep because you know that your nerve is still intact and your vocal folds are coming together.
Right.
Do you use that every time you're doing neck surgery, or when is that indicated?
Yeah, so I actually don't do ablative neck surgery. I'm purely a
You just build
person.
things back.
I just put it back.
You put it back.
Yes, it's a little bit all over the place. I think it's surgeon specific. It's what they're comfortable with, what they're trained with. Some people use the NIMS quite a bit. Some don't. I think one of the worries with the NIMS is that there can be a lot of false positives. Just moving the neck can make it stim, so then you end up with some alarm fatigue, right? Yeah. And I think the folks that don't use it, fundamentally, they're like, the anatomy is the anatomy. Good surgical technique is good surgical technique. Again, I don't do ablative surgery, so it's hard for me to.
Yeah. I mean, I typically have used it mostly when I have a reoperation, and I think the anatomy is going to be a little questionable, and we're going back through sometimes concrete, trying to get to the esophagus behind the airway, or get to the airway, or maybe there's a TE fistula. There's some situation where the anatomy is not normal, and we'll be looking at nerves and we'll be saying, is that it? Maybe that's it, you know, and maybe it's ANZA, maybe it's recurrent nerve, and it's not always as obvious when things are shifted, prior surgeries happened, or diseases happened. So that's when I tend to find some value.
So I don't use a NIMS. I do use a nerve stimulator when I'm doing my nerve procedures, but we we watch the muscles jump, right, which is hard in the larynx.
Yeah.
But when you have the larynx open and you can actually see the muscles, so I'll nerve stim there for nerve identification.
Yeah, I can't remember ever doing a surgery where the larynx is wide open.
Yeah, so we can actually see the muscles, and so we'll stim it and look at the muscles jump. So that's, I guess, but I don't use a NIMS.
Yeah.
It's more like, oh, is this a nerve? And then we'll stim it.
Good. Well, sounds like we've gotten down into dirty details
Yeah.
as well as sort of broad overarching themes. Thanks for joining us for the
of
podcast
course.
today. I hope patients, providers, surgeons, anyone listening to this podcast can find value. And the Lung Institute is great because it brings all the different providers together and helps us to learn from one another and find ways to work even more efficiently together and maybe prevent injury, get an earlier repair, an earlier recovery, and really sort of practice best evidence guidelines. So thanks again for the ever so fickle recurrent laryngeal nerve.
Thanks for inviting me. I think the multidisciplinary, interdisciplinary care is so much better for patients, and getting us out of our silos, I think, is wonderful.
Yeah, we are absolutely blowing up those silos.
Yeah.
So good. All right. Thanks so much for joining us today, and thanks for joining us for the Baylor College of Medicine Lung Institute.